Hey guys, welcome back. This is Russell Linville, sports physical therapist. This is part of the Become a Better Human project. And today is Throwers Thursday. So last week we talked about what do I look for in an initial evaluation for a baseball player or a throwing athlete. What I want to show you today, we have a couple people. Tommy Olson, who's our thrower, and Nathan Waltzine, who's our physical therapy intern. We're going to be going over how do you measure shoulder range of motion effectively, based on what the literature suggests is the best way to do it. So, what you're going to need is a towel roll. So we've just taken a large towel and we've put tape around it, made a nice thick towel roll. We're going to need to support the person's arm with this towel roll. You're going to need a goniometer, or sometimes you can use a digital inclinometer, and that's going to be an effective way to actually measure the range of motion, which you can then track, of course, over time, like with any goniometer measurement. So for a right-handed thrower, of course, you'll be on the right side. You're going to take their arm. We're going to look at shoulder rotation first. We're going to look at external rotation first. You take that towel roll, you're going to put it underneath their humerus. What I like to do is that right now he's kind of in the scapular plane, right? So his arm's not resting on the table. We think about how the humerus articulates with the glenoid. It's actually not straight across. There's a little bit of an anterior tilt to the glenoid, so we're going to need to put him in a scapular plane to get true glenohumeral range of motion. What you're going to do is then come in all these measurements, you're going to stabilize the patient's scapula. Again, we want true glenohumeral range of motion rather than having scapulohumeral motion that's going to give us a false sense of their range. So you come around and take your palm of your hand, you're going to block their scapula here. So all I do is I go at this angle, where I'm pushing their scapula into the table in downward or depressing their scapula. So now, as we do rotation, they're not getting false motion as if they were shrugging to get up. You get right to the side, their elbows right across from their shoulder joint, you're stabilizing the scapula. You take their hand and you're going to take them passively into external rotation. So right there is where this patient likes to passively rest. We call that tension point 1, right? Or stretch point 1. We're going to try to take him back to look at all his accessory passive motion and mimic what it would be like if him throwing the ball. So again, scapula stabilized. I'm going to grab near his wrist. I'm going to gently push down until he tells me to stop. You just let me know, Tommy. Right there. And then Nate's going to come in. You do need two people to help get a measurement here, and use a goniometer and measure what the range of motion is from that 90-degree position. So that's how you would do it. This would be considered neutral, going backwards, external rotation, and then next, going forward, internal rotation. You're going to switch your hand position just a little bit. You're going to palpate and find the coracoid process. You're going to depress again the scapula here. By grabbing the proximal forearm, you're then going to take them into internal rotation. What you'll feel when they maximize that range of motion is that their coracoid is going to pop into your thumb. And so that tells us that right now he's run out of glenohumeral range of motion, and he's trying to get scapular tilting to get more internal rotation. So we're going to stabilize there, take him down until we feel that nice hinge feel, making sure that scapula is not tilting forward. And so in him it's here, and of course we're going to measure just as we would with external rotation, but now it's internal rotation. Good? Then I like going into shoulder flexion or overhead range of motion. Again, remember all these were blocking the scapula so we can see what the glenohumeral motion is. Here, if you come around here, you'll see I'm going to place the palm of my hand right into the patient's armpit. And what we're trying to do is press onto the anterior surface of the scapula so we can block it down to the table. So I just take the butt of my hand, I add pressure here, and then I take them up into an overhead position. And I'm okay with them going into a little bit of a Y or scaption type motion here. And then we get this range of motion here. This is just taking like a normal goniometer measurement with shoulder flexion. So we get that one as well. And then the last one, you keep your hand position the same, your stabilizing arm. And we're going to do cross body adduction position here. We'll get this measurement by placing the pivot point of that goniometer right at the acromion, and how far can they reach across their body with a stabilized scapula. So if they have poor range of motion, a lot of time in throws, we'll see them when they only be able to get right here, where their other arm can get all the way across, and that might suggest they have some reactive muscle tightness in the posterior musculature. So what I'll do is in the notes of this video, we're going to put some studies, reference some studies for you of why this range of motion is important. Huge increased risk if you have lost range of motion, especially if you're injured and then get back to throwing. So if you guys have any questions, write some comments to me, send me a message. We'd love to chat with you guys. Thanks for viewing this video. Once again, my name is Russell Linville, as part of the Become a Better Human project. Thanks for tuning in.